Good afternoon or good day. Welcome to the AIAMC webinar today on pharmacy and GME collaboration. My name is Kimberly Pierce-Burke. I'm the Executive Director of the AIAMC, and I'm so pleased today to have two of our member institutions being represented and sharing their stories of successful collaboration between pharmacy and GME. We have from UnityPoint Des Moines in Des Moines, Iowa, Dr. Ali Schlichter, who's the Pharmacy Residency Program Director. Along with her is Dr. Mark Nagel, who's a recent pharmacy grad. And joining them to round out the team is Dr. John Yost, the Vice President for Medical Education and Research, as well as Dr. Shanto Ayers, who's the Executive Director of Medical Education at UnityPoint Des Moines. Joining this team is a team from a little farther east, St. Luke's University Health Network in Bethlehem, Pennsylvania. Speaking on behalf of their team today will be Dr. Justin Miller, who is their residency program director for pharmacy, along with Dr. Frank Lynn, who's a fourth-year chief resident in internal medicine. And we may have some folks joining in from their GME office as well. So with that, you probably saw the note in chat. If you're not on the speaking team, if you wouldn't mind muting your lines and turning off your camera so that we can really focus on our speaking team today, we would appreciate that. I encourage you at any time to type questions into chat. We'll be sure to address those once the prepared comments have been completed. And also, we are recording this session, so I hope you'll enjoy it and share the link for the recording with your colleagues. So I'm going to start with UnityPoint. So Ali and Mark, we've chatted before, and here's a shameless plug for the AIAMC podcast. We actually did two podcasts this summer with the UnityPoint team, so we hope you'll check that on our YouTube channel. But I'd like to turn to the two of you first. You've had a really nice history at UnityPoint of working with GME. I think Mark shared a story, particularly maybe with internal medicine residents there. So, Ali or Mark, which one of you would like to get started and share some of your story with our members today?
Yeah, I can go ahead and get started first. I'll give a little bit of a history to our program here, and then I'll give the floor to Mark so he can talk about a few more recent examples, encounters that he's had for GME collaboration. So our pharmacy residency program has been around for over 20 years, which is fantastic because we have been integrated with the GME team for a long time. This started as a collaboration between the College of Pharmacy, that's in Des Moines, Iowa, Drake University College of Pharmacy, the medical consortium here, and then obviously the hospital. One of our pharmacists kind of integrated himself within the medical residency team, and then he has since brought along the pharmacy residents to share these experiences. So myself, when I graduated from pharmacy school, I actually did the pharmacy residency here, and then I'm an example of one of our many pharmacists who has decided to stay on here afterwards. So that pharmacist who started our pharmacy residency program, he's responsible for providing education to the medical residents, and then he brings the pharmacy residents along too. So he's involved in precepting monthly journal clubs. A favorite every year is his RUP, or rapid update presentations that he gives along with some providers. So definitely there is that collaborative approach or discussions from the education standpoint, and not just at the bedside as well. So this allows kind of education to be shared freely with residents and attendings, both from the medical side as well as the pharmacy side. So like I mentioned for myself, so many of our previous residents have stayed on post-residency, which is also the same with many of our medical residents. So oftentimes you develop this relationship when both residents are taking care of the patients together, and you may go from the ped service to the ER to the internal medicine service. And those residents are, whether it's pharmacy or medicine, are oftentimes doing the same rotation. So, your paths cross many times throughout the year. So it's always fun when the pharmacist ends up staying on and the medical resident ends up staying on, because you already have that foundation built, that groundwork of collaboration, so that you continue to have that collaboration kind of a second nature throughout the upcoming years. And then one other thing that I wanted to touch on, which I feel like is important from the collaboration perspective, is medication errors. So medication errors is unfortunately, to err is human, is something that happens. And medication errors can be a preventable cause of patient harm. And I think that having pharmacists directly involved in patient care is one way to also prevent these medication errors. So, having that collaboration on rounds when the pharmacist knows kind of what the provider, the attending, the medical student, the resident is talking about, is considering for the patient, and kind of being there in the moment, we're able to kind of share some of our knowledge on, drug metabolism, renal elimination, maybe some antimicrobial, stewardship guidelines, or even our most recently updated antibiogram, which has some additional information as well. So I think having the pharmacists involved is truly beneficial in decreasing the potential for, an AKI if a patient that, really needed a renally dosed antibiotic. And it's also twofold. I mean, I've been on rounds before as a resident, as a pharmacist, and have learned from those providers sharing their medical stories in rounds, and kind of teaching the resident and teaching the medical students about, the ABCs of chest x-rays. And, that's not something that we see in pharmacy school, but that also helps us to become better practitioners too. So really that collaborative approach in rounds as well as in the classroom is beneficial for both sides, pharmacy as well as the medical residents. So I'll give the floor to Mark now, and I'll let Mark share some examples that he's been involved in recently.
Yeah, thank you, Allie. As Allie mentioned, I am one of the recent graduates of our residency program. So I finished pharmacy school in 2024 and then finished the residency program at Iowa Methodist Medical Center just in this past June, and then I stayed on ever since then. So I've been an official clinical pharmacist operating on my own for about 3 months now, which is super exciting, 3 or 4 months. But having gone through the residency program, I just wanted to touch on some of the examples and times that I had opportunities to collaborate with our medical residents throughout my training. And kind of taking it from the start, one of the things that really drew me to the program was knowing that this was a teaching hospital and I'd have those opportunities to collaborate with medical learners, because that was something that even throughout pharmacy school, when I did my like practice environment, and basically these mini internships, something I really enjoyed was getting to collaborate with medical learners and residents and all the way up to attendings, because I just feel like so much learning happens on rounds and in those situations where you get to be one-on-one with, physicians and learners. And that setting is something that was really something that I wanted in my career. So that was what drew me to a program like this in the first place. But I guess some more specific examples. So throughout pharmacy residency, you do all these rotations on various different clinical practice settings. And I think that I collaborated with medical residents on probably 80%, if not more. There were a couple that were more management based or just pharmacy specific. But for the most part, I was interacting with medical residents on a daily basis, whether it was face to face in rounds or, phone calls, spoke, secure chat, Epic secure chat, all that sort of thing. And I think Allie touched on this, but just the amount of learning that can occur on those face-to-face rounds where something comes up that maybe they are able to teach me about the pathophys behind something, which is not something that I would have trained in or like specifically learned about in pharmacy school. Or maybe I can teach them about the pharmacotherapy or like a little niche mechanism of action thing about a specific drug. And I think having those opportunities builds a lot of trust between pharmacy and then like our medicine and physician partners, and building that trust from an early standpoint kind of leads to better collaboration in the future. So, I had residents that I worked with early on in the year in my residency, and then I maybe had a rotation with them later in the year as well. And we had already kind of built that trust, and they felt comfortable asking me questions, and I felt comfortable asking them questions and making recommendations. And I think that was something that was really beneficial to me. Kind of transitioning more into the project side of things, where I had opportunities to collaborate with GME and our medical residents. So a few examples. Um, we do journal clubs. So we did these journal club series that we were always invited to attend. And then all of our pharmacy residents also presented a journal club, and that was a really great experience. I presented mine on like initial antibiotic choice, empiric antibiotics and sepsis, and a lot of the medical residents thought that was interesting. And I got good feedback on that, and I learned a lot from their presentations. We also have like a QI presentation. It takes over the course of a little bit of like a probably like 2 or 3 weeks, but we'll all present our QI or research projects at the end of the year. And it's really interesting hearing what the research that both like the medical residents and the pharmacy residents are working on throughout the year. And then they always invite us to their grand rounds presentations throughout the year. That's like an open invite on my calendar. So I went to those when I could. There was lunch available, which was super nice, but also all this great learning. Oftentimes attendings were presenting at those or senior and chief residents. So that was a great opportunity for us as pharmacy residents to attend those. And then I also just did some in-service teachings throughout the year. So like one thing that I did an in-service teach on was QTC prolonging medications and antipsychotics. And that was something that I was able to kind of use my specialized knowledge to present something to medicine residents. And there were, various times throughout the year when I learned things from them. So I think just getting all of those opportunities to work together on a day-to-day basis was really beneficial for me as a learner and something that I continue to do in my career now that I am no longer a resident and working as a clinical pharmacist. So.
That's a wonderful story, Allie and Mark. Thank you so much. And what I'm hearing from this is there are some milestone moments, like the QI day or research project, or but then there's also just this ongoing, open invitation, as schedules allow. And I'm also hearing how much we learn from one another, that this really is very much benefit on both sides. John Yost, as the Vice President for Medical Education and Research, as the, really the senior academic leader at UnityPoint, from your view, what are the advantages to the medicine learners? That's my first question. And then my second is, how did this all get started?
Maybe I'll start with the second question first, because as I sat here listening to both Mark and Allie, it allowed me to reflect a little bit upon what I have seen over the course of my career. And as you and I've discussed, I remember as a first year resident 40 years ago having a PharmD on our medicine service. To this day, I remember Roger fondly, not just because he was a nice man, and he was, but he was enormously valuable to us as a team. Yet at that time, it seemed radically innovative to have somebody who was not a doctor teaching on a medicine service. I learned a ton from Roger about daily patient care, as well as some of the more even arcane elements of pharmacology and just what Allie and Mark live day in, day out. But what I have seen at the same time that in medicine we have approached more of a team-based paradigm has been refinement of the model. So now what I see here at UnityPoint Health Des Moines is, the pharmacists and the clinicians, particularly in medicine, but in other specialties as well, pediatrics and surgery, for example, an almost seamless melding together in terms of the care that we provide and the learning that we gain from one another. So how has it changed? I think it's much more refined. I think it's more seamless in terms of how that care is delivered at the bedside. And I don't think anybody finds it surprising. I would feel a little bit lost without a pharmacist on the medicine team, maybe more than a little bit. I think that what the medicine residents in particular, but faculty as well, benefit from is the knowledge that pharmacy has to share. And as Allie was talking about, the individual that started this with us, someone who's become not just a trusted colleague, but a good friend of mine, he would, as she said, there was a lot of teaching at the bedside. He was there on daily rounds. He would go to the ICU. He would go to the patient's bedside. And he would engage in some clinical teaching. It was all fully integrated with the attending physician. And yet there were also the didactics that he would present, and some of them were just enormously practical. He would set aside these 15 or 20-minute presentations on rounds where he would talk about bugs and drugs. And that was a repetitive little lecture that he would give that was just an introduction to antimicrobials and how to select an antimicrobial for a particular infection. My personal favorite of his was on the management of constipation. And again, it was just enormously practical, while at the same time, as Ali said, you know, whether it's at grand rounds or the day in which we present QI projects, we would see a PharmD or a PharmD resident also present didactic material that supplemented and added to the knowledge that the medicine residents had. And as I said, the attendings as well. So everybody gained. I really believe that each discipline makes the other better.
Mm-hmm. Mm-hmm. Well, it truly takes interprofessionalism to the next level. There's no doubt about that. And to have a 40-year history is pretty darned impressive. I've always thought in GME, if you can do something for 3 or 4 years, then the trainees think this is the way we've always done it, you know, because all you know is what is all you know. But to be decades in is certainly very impressive. Well, we have more questions, but I want to be sure we turn to our team members from St. Luke's in Bethlehem, Pennsylvania. We have Doctors Justin Miller representing the pharmacy residency program and Dr. Frank Lynn, who's chief resident 4th year in internal medicine. Gentlemen, which one of you would like to start with the St. Luke's story?
I can start. Maybe just kind of reiterate from the pharmacy side, and then Frank, if you want to talk about kind of your side afterwards. Yeah, so our experience here at St. Luke's is very similar to what Ali and Mark shared in terms of the rounding. You know, we've also been doing this. I mean, we've had the pharmacy residency for now going on 18, 19 years, I think, at this point, back before my time. But in terms of integration with the medical residencies, one thing I think kind of where helped get it started was we have here like our affiliated School of Medicine, the Temple St. Luke School of Medicine, and a lot of our clinical pharmacists actually hold like adjunct faculty appointments at the School of Medicine, and so we're already involved in the teaching of the medical students, a lot of which then come on to be medical residents, and it kind of makes a nice natural transition then into kind of those didactic lectures that take place during rounds, or even kind of off the cuff kind of learning that it takes place during rounds, which is really nice. One other thing that I wanted to kind of highlight is we actually have a couple of our clinical pharmacists that offer that actually take medical residents for a kind of a full like rotation, so as their like primary preceptor. So they're usually like a 2-week elective that they can spend with our pharmacist, and they basically go through as if they're our pharmacy resident. So come in, look, you know, work up the patient, but focus on, you know, the medication standpoint, you know, the things that we look at, like everyone has mentioned before, you know, the right drug, interactions, dosing, you know, things like that. And then go on rounds as if they're the pharmacist and make recommendations to their colleagues and things like that. So they really get kind of that experience of what it's like to be a clinical pharmacist and kind of see that side, and hopefully develop those skills of looking at medications from that standpoint a little bit more in depth than maybe they would otherwise. And so I know from you know, from what I've heard, and I guess, you know, Frank can speak to this. I'm not sure if he took that elective, but I hear great things, you know, great things coming from that experience that our preceptors offer. And then kind of the additional side of that is I know they do a lot of like they were saying, like journal clubs and things like that. And then in terms of just like one story that I think kind of like brings it all together, when I was a resident, so I also was a resident here at St. Luke's and then stayed on, obviously. There was a internal medicine resident that I worked with very closely. We just so happened to be on a lot of rotations together. And then it kind of came full circle when she had gone on to specialize in geriatrics and stayed on here at St. Luke's. And then we had a pharmacy resident who was very interested in kind of getting more exposure to that world of geriatrics, but we don't have a designated pharmacist in that area. But I was able to reach out, through that connection that I made previously to Dr. Krasa and set up that rotation. So she actually precepted our pharmacy resident then on rotation. So I think kind of like what we're saying, I think just building that environment, that interdisciplinary environment where, we can all learn from each other and all, grow better, I think really just is a great opportunity.
Yeah, Justin, I love about your story that I'm hearing this. It's really about relationship building, and those relationships seem obvious when we're in the trenches of training, but they're really going well beyond while you're actually in training. It's the relationships you've built that you can draw upon to enhance new folks coming in and up through the pipeline. So most impressive. Frank, what would you like to add to that?
Of course. Thank you for that, Justin, as well. Thank you to Ali and Mark as well. I think all of that was actually very I expressed similar sentiments. Having been a recent graduate myself as a medical resident and now being a fourth-year chief resident, I will say that, from my current experience, having rounded with inpatient team, guiding medical residents on my own, and kind of reflecting on my own personal time in residency, I can definitely attest to the fact that, our relationship with the pharmacy department is very strong. And I think they've been nothing but, educational and great from my perspective. And I will say from my own recollection, I was actually able to get some feedback from, current medical residents at St. Luke's myself. And a lot of them have expressed the same kind of thought that a lot of the ICU pharmacists that they've worked with who routinely kind of bedside round with us, even if it's just, simply by reaching out remotely through Epic Secure Chat as well. They've always been super on top of, providing recommendations on, antibiotic adjustments for patients. Usually they're, something that we as medical residents may not be as knowledgeable about or kind of thinking of is, just adjusting antibiotic dose based on, patient's weight or their kidney function. So I would say from that perspective, they've been really, crucial for our team's success and for the patient's outcomes from that sense. And then there's actually another story that I had, and it was actually, patient, with diabetic ketoacidosis in the ICU. The pharmacist that we had over in one of our campuses in Allentown, who's like extraordinary. She's extraordinary as a teacher. Like she will literally, I feel like she knows more than we do sometimes as doctors. But essentially, she was just really emphasizing to us as residents to really be more aggressive with electrolyte repletion, with the potassium, magnesium, and based on our hospital's protocol, we check labs every 4 hours. And basically, the idea that the pharmacist had told us and really tried to instill was the fact that sometimes these electrolytes aren't fully delivered when you check them every 4 hours. So when you check them so frequently, it might not be completely accurate what their levels might be. So even tidbits like that and education points can lead to protocol changes within our hospital to potentially check labs maybe a little less frequently, like every 6 hours, for instance, for a patient with DKA. But on top of that, I will say the pharmacists, they do a lot of their own chart review in our network. So whenever I'm doing missions, admitting a new patient to the hospital, they always kind of reach out to me if they feel like there's need to kind of change, something that I've ordered on their medication reconciliation list. And on top of that, maybe after procedure or after some other circumstance, they'll kind of notify you if, medication should be unheld, sooner than later, just so that patient, isn't getting any delay of their treatment for their chronic conditions. So obviously those are some of the kind of the key moments I was personally able to reflect on. So they've been crucial. And myself as well, I've been able to attend at least a few journal clubs or grand rounds, from the pharmacy department. And, I think all of those lectures were, crucial. One of them was regarding, perioperative management of blood thinners, which I think from a medicine standpoint, as, primary physician, as a medicine resident, I think is really important to know and be educated on.
Well, Wow, that's really incredible. And for all of you joining in, thank you again for being here. And I challenge the panel to think about not only the obvious, how is this enhanced learning, but might you have examples of how this is actually enhanced and improved patient care? You know, at the end of the day, that's why we're all here, is to improve patient care and learn along the way. So really a compelling example about the diabetes patient in the ICU. JP, Dr. Orlando, I'll turn to you similarly as we did with John. Excuse me, your reactions to what you're hearing, you as the Chief Graduate Medical Education Officer and DIO at St. Luke's. How do you see this collaboration, this relationship building as really being 1+1 = 3, you know, improving the learning and ultimately enhancing patient care? Give us your
Yeah.
perspective.
Yeah. And thanks, Dr. Lynn, and thanks, Dr. Miller. Really appreciate it. And so some of you could see the posters behind me. Those are residents, and Frank, I've had you circled on that and green for a long time because you've always been great. And so thanks a lot for serving as our chief resident, and then for Justin for being the program director for the pharmacy residency. We have a couple of accredited pharmacy residencies and fellowships here. So, and Justin has always been really key for that. So thanks, to you both. And, there's a couple different comments to make on this. I think the first one is that, delivery of care is a team. It's a team. It's all about teamwork, team sport. I mean, it's all about the team on the floor. And, Kimberly, you talk about the recent, its application to patient care. So like I recently had a loved one in the hospital for 8 weeks and in the ICU. And I went on rounds a lot. And one of the things I really, really valued was that interaction between the attendings and the nurses and the pharmacist on the floor when they were doing rounds, the inclusion of the patients into the discussion. And I'm not just saying that they just kind of meander over, but actually that they go in into the room and say, hey, Diana, would you like, we're doing rounds now. Do you want to, kind of join us? Even phone calls to family members. Hey, we're doing rounds now. Do you want to, attend family meetings once a week, right? And Thursdays at 1, and you have at the table there, the whole healthcare team. And so that is super, appreciative. And when you see that type of collaboration and the interaction between the teams, asking questions, clarifying callbacks, all those good team behavior things, it does make a difference. And so it's really fortunate that, we have people like Justin and Frank, and all of our, residents and program director leaders, chief residents, attendings, that pharmacists that really kind of make that happen. And it's the culture that they're in. I think a lot, like where you train matters. Like if you work in a high quality environment, that's going to have and the research shows this, there's an imprinting effect 14 to 15 years later that happens, if they decide to go outside of the system. So, those things, carry forward. And I've been at other places where I have not seen the pharmacist, or I haven't seen some of the other team members, especially on rounds, drawn into the conversation when it comes to how care is delivered. And so we do a lot of leadership training. We hire great people, and it's a very friendly environment here. We're a top 100 top workplace to work at. St. Luke's just got named like the #1 place for patient care and patient safety. And you know what? It's the microcosm for that is what happens on rounds, as I experienced directly with the whole healthcare team, interacting back and forth. And I think like Justin was saying, having the pharmacist integrated into the Temple St. Luke's Medical School, like right from the start, that sends a message. Like everybody's part of the team here, so that's a key thing. And so like all of our pharmacy residents and fellows are they're all residents and fellows like everybody else. All of our other otolaryngologists, urologists, primary care, all that. And so, which is different because I think some other places that I've heard and that I've been at, there's this tendency to kind of treat a little different. And that's a reflection, I think, a lot about culture and the microsystems that they're in. What cities there are, areas of the country, I think that kind of sometimes influences that. But yeah, I mean, I don't know, Frank, Justin, I can't. I'll praise you to the hill because you guys are great. And I've been on, from a family perspective, been on the other side of it. So it's great to see that collaboration because it makes a difference.
Well, definitely. When you experience something personally, you see the fruits of the labor through a very different lens, and a very powerful lens, and the lens that matters most, again, which is patient care. So I welcome anyone to put a question into chat. If you're an extrovert and want to turn on your camera and ask a question, that's all right as well. I imagine if I were in the audience, and I did not have the kind of experiences that have been described over the last several minutes, I would have the question of where to begin? Like, it sounds like in both of these examples, there's a very rich history of collaboration that you all have really benefited from, and you've helped grow and flourish. But what if my institution, quite frankly, like I work in pharmacy and I reached out to GME, it kind of never went anywhere, or vice versa. How do you get started? Any advice for our members listening in that maybe don't have the lovely legality that's been described here today?
Yeah, Kimberly, if I could just jump in, add into the comments, like what's the playbook, right, for others, to kind of look at to get to that point of collaboration, teamwork that leads to not just great training experiences, but also the patient outcome piece.
Yeah, I'm going to jump in and just add one quick thing. And that is, I think obviously it depends upon having the right people. And most institutions will have, of course, PharmDs. So identifying somebody at that institution who is interested in teaching. I don't think it's a hard sell to a medicine service to add PharmDs onto those clinical services. But the other thing that I really think is advantageous is to sell it to the C-suite. If we can explain to the COO and CFO and all the other C's up there that this is better patient care, that we'll see reductions in length of stay, I think, that we'll see fewer adverse drug reactions and do a better job of identifying our mistakes and learning from our mistakes. I think once you have C-suite buy-in, you're probably 80% of the way there, because I don't honestly think it's hard to find a PharmD interested in teaching physicians. And certainly I've never found a physician, maybe a few that are more, as my wife would say, capateste. But most are, of course, extremely open to the idea of the PharmD and what he or she has to offer.
That's great. Thank you. We do have a question in chat from Titus Shears, who's with Cleveland Clinic Akron General. And he says, besides the history and sustaining commitments of the involved faculty, have you developed sustaining shared resources that continue the relationship? So academic resources, stipends, etc. What resources are available in your two respective institutions to really have those sustained shared resources?
I would say initially the pharmacist that I was alluding to and that Dr. Yost alluded to, it was a faculty member from Drake College of Pharmacy. But recently, within the last 2 years, we have started a new ER medical residency program. And a lot of our current staff pharmacists do participate in several of their weekly discussions on several disease states. They have like an 18-month rotation that they utilize a cycle. And that was a decision that our pharmacy leadership team kind of took to provide the project time for the pharmacists to come up with those lectures, obviously pharmacotherapy related lectures, but to provide those pharmacists with that time and the resources to go to their weekly conference and present on several of those topics. We viewed that as a way that our pharmacy team could contribute, but also we were able to provide that education to our pharmacists as well. So not only do the pharmacists educate some of the medical providers on some of these topics, but we're able to use it as some of our department education as well. But I think exactly like Dr. Yost said, making sure that your director of pharmacy, your senior leaders are willing to pay for these resources. And, our pharmacy team does not get paid for this, but this is something that we felt was beneficial to provide the opportunity to really progress care of our emergency department patients and educate the providers that are taking care of the patients down there.
Mm-hmm. Great. Thank you.
It's been mutually beneficial for us and for Drake University, the College of Pharmacy at Drake University, in that, of course, now they have a place where their students can come for clinical rotation. So certainly the College of Pharmacy at Drake has benefited. We benefit from their presence, and that has ensured that these PharmDs that are on our staff, who are also faculty at Drake, become integrated into our teaching service. We've got another PharmD over at Lutheran, which is our sister hospital, who's actually on faculty at the University of Iowa. She's a 0.5 FTE with us. And so again, we certainly have the buy-in from the university, including the financial investment, and gain from her knowledge and her teaching skills. The other thing, Titus, that I would say is that all parties benefit from the research that we do. We'll publish papers that include PharmDs and MDs and DOs. And so that goes to their scholarly activity and achievements.
Great. I'm curious, those joining in, and you can just put yes or no into chat, this idea of the adjunct professor. So is that the case for you locally, that your pharmacy colleagues have that university affiliation? You just want to, I'm just curious to get the feel of the room. If you could put yes or no.
Some of ours do. Okay. Some of ours do.
Mm-hmm. Titus says yes. Okay. Cool.
And Kimberly, I just want to add, the pharmacy department is also embedded in our CME. There, Dr. Brian Benson is the executive director of the pharmacy department, and he's on our CME committee, helping with, planning educational programs, and we collaborate with them as well as part of our CME activities on our campus.
Mm-hmm.
That's fantastic. Can I ask a follow-up question to that?
Sure.
Are you also, do you have that joint accreditation?
Dr. Yost?
Oh, the pharmacy, nursing, and medicine?
Yeah.
We actually don't, JP. We've flirted with the idea, but we've never really carried it through to execution.
Yeah.
Our colleagues in Iowa City do.
Yeah. No, we're looking at it after we have a CME reaccreditation, like in 2 months. And so we were thinking afterwards to go for it. So, but it's certainly something we should connect on.
Yep. Any other thoughts? Oh, here we go. We have a question. How have you integrated pharmacists into your ambulatory clinics? So we've talked a lot about rounding. We've talked about shared educational experiences. What about integrating pharmacy into ambulatory clinics?
For us, now this is I'm gonna give you as much information as I know, as it's not my practice area, but so I do know here at St. Luke's, so we have I think we're up to 5 actually ambulatory care, or I believe their title is officially like clinical integration pharmacists, but essentially they operate out of ambulatory care clinics, and so so they have their own patient list. So they see patients right in the same offices as in our in some of our primary care offices around our area here, and they our primary care providers are able to essentially refer patients to them to go to the pharmacist to see. They do a lot of diabetes management, heart failure medications. I think those are like the 2 big ones, that the 2 big disease states that they handle, as well as I'm sure some other ancillary things. But yeah, so we do offer that, which I think is again just another great opportunity for pharmacists and provide and physicians to work together and collaborate on not just inpatient side, but also on that outside ambulatory care setting.
Mm. Thanks for that, Justin. Megan has shared our struggle within our health system is getting funding approved for more ambulatory care pharmacists. And again, I think that, John made the good point of sharing with the C-suite what a win-win proposition this is, not only for education, but for patient care, fewer medication errors, decreased length of stay, etc. But yeah, it often does come back to funding, that's for sure.
Am I able to jump in here? Sorry.
Sure.
We do have M-Care pharmacists. Some are paid for through Drake, but others are actually through UnityPoint. And we're able to leverage some of our 340B cost savings dollars, which our ambulatory pharmacists are able to so like a patient on a GLP-1 medication there would be a consult to the ambulatory care pharmacist, and then that pharmacist would enter the script for that medication through the collaborative practice agreement. And then there's some cost savings that's being done kind of behind the scenes. That way we're able to get drug at a cheaper price because of 340B pricing opportunities. So that's one way that we're able to kind of leverage that as a benefit from us. We get to use our outpatient pharmacy to dispense these medications, and we get the medications at a lower cost, which means essentially the pharmacist's salary is essentially getting paid. So if 340B options are available for your site, that might be something that you could look into. So you are getting a return on investment for that, and not necessarily a cost center, which is what typically pharmacy usually is.
Mm-hmm. Great tip, thank you. And Titus, I don't mean to put you on the spot, but your notes got a little broken up with other great comments. Can you just share with us? I know you do great work there. I had dinner last evening with your colleague Cheryl Goliath, and she said there's a lot of cool things going on there. So can you just articulate a little bit of what you put into chat?
Well, like the last comment, we have Akron General, one of the Cleveland Clinic hospitals. A pretty vigorous PharmD educational program that has 4 residencies, and so where those exist, we've both the growth of those PharmD residencies, but also where the services, as was mentioned by Ali, the sort of the linking of 340B payment with pharmacies in our ambulatory area as a way of providing that service that is also fits with the ACGME guidelines around, in particular, our family medicine clinic. But also we have embedded in our medicine clinic the idea of PharmD-led specialty clinics that would help with, say, anticoagulation issues or related to refractory diabetes as a way of, as you said, leveraging 340B possibility pricing in that environment. And then also we tried to look where we had other potential already investments in expensing, for example, whatever our resources were for online education, making sure that there were PharmD resources as part of that, so that our PharmD residents or faculty could have access to that, that we think about that as we're trying to purchase resources to make sure that those individuals that we were bringing them together, not only on the inpatient or outpatient teams, but that we were finding other opportunities to do, whether it's, as mentioned, shared educational conferences or those sort of activities as well. We made the commitment some years ago to look at our food spend around residents. There always was a food spend, and extending it to our PharmD residents as a way of increasing the likelihood of those conversations continuing, say, through lunch or through an evening meal, that were of great value, and found that that was a way of leveraging dollars we were already spending in a way that would allow us to sort of continue to increase those interactions. So I think we keep thinking of those sort of ways as ways of making this sustainable, and not wanting to just be that really good faculty as they pass on or move away or something happens, that it wasn't self-sustaining, trying to find ways to make it self-sustaining.
Right, right. Thank you so much, because you're right, Titus. What you speak to is you've been a real champion for this work, and you need those champions, but champions can come and go. So what can we do along the way to really sustain the effort is so important. And I got to just chuckle. I mean, it's been 25 years since I've been in the trenches of GME, but free food,
yeah,
it's timeless. It's timeless. It works very well. Let's see. I think we might have another comment here in chat. Our colleagues at Riverside in Virginia, Tanya is saying, thanks, Allie. Oh, with the politics surrounding 340B advocacy and potential federal funding jeopardy, it's a good reminder to advocate through medical organization avenues. The 340B programs support medical education in the ways you mentioned by allowing additional pharmacist resources. So well put, Tanya. I think we can all agree, without getting political, that today more than ever, medical education research, it really has to have strong advocates. And obviously you all are, or you wouldn't have signed on for this webinar today. I'll do one last shout out to see if there's any questions or comments. We try to give you back 5 to 10 minutes on your calendars before you go to the next one. This has been a rich discussion. Any closing thoughts from our panelists? Well, I would just add that a couple years ago, the board of the AIAMC decided that of all the national organizations out there supporting medical education and research, we were very uniquely poised to expand our focus beyond GME. GME will always be our home. That's where our roots are. But through the work of our national initiatives, we've been doing interdisciplinary. Before that was a catchy word. We've been doing that now for 17, 18 years through our national initiatives. And we asked you, our members, with whom have you been collaborating? And with whom would you like to collaborate in the future? And both answers were overwhelmingly pharmacy. So that's why we've been bringing you this pharmacy education. We hope it's given you some ideas. We hope that the exemplars you see from your colleagues in Des Moines, Iowa, and Bethlehem, Pennsylvania will inspire you to extend the collegial hand of friendship between pharmacy and GME, and to other learners in the clinical learning environment. This is the first step of what we see as really trying to support all learners in the clinical learning environment, and where can we start with those collaborations. So I would like to, again, very sincerely thank Drs. Schlichter, Nagel, Yost, Miller, Orlando, Lynn, Ayers for being with us today. And oh yes, and thank you for the reminder. We scheduled this week because it's National Pharmacy Week, and so it's a great time to thank our pharmacy colleagues for making our education better, our lives better, and again, ultimately enhancing patient care. So with that, we'll say good afternoon, and the recording link will be sent to all of you who registered. Please do share it with your colleagues in pharmacy and GME. Thanks, everyone.